Alterations in elimination, renal. This is pathophysiology and management. The urinary system functions are regulatory, excretory, and hormonal. The urinary tract system will excrete excess water and nitrogenous waste products from protein metabolism. It assists in maintaining acid-base and electrolyte balance and produces a hormone that's used in blood pressure regulation and a hormone that's used in stimulating red blood cell production. So with regulation and excretion, urine production will occur in three processes. We have glomerular filtration, tubular reabsorption, and tubular secretion. The kidneys and lungs will work together to maintain the body's acid-base balance, with the lungs blowing off carbon dioxide, which is an acid, and the kidneys excreting acid or retaining sodium bicarbonate. Base levels will be maintained when the kidneys conserve that bicarbonate, which is a base. Urine elimination, the amount is going to be affected by how much fluid we take in, what the environmental temperature is, the body temperature, the amount of diaphoresis, vomiting, diarrhea, and some medications, as well as some medical conditions. Blood pressure will be regulated through fluid volume maintenance and the release of the renin hormone from the kidneys. With severely depleted cardiac output, blood will be shunted to the heart, the lungs, and the brain away from the kidneys through vasoconstriction. With prolonged vasoconstriction, however, this can cause the death of the renal tissue. When there is decreased oxygen in the renal blood, then the kidneys are going to secrete erythropoietin, and this stimulates the bone marrow to produce red blood cells. So as we age, we find with the renal system that we begin to experience nocturia, which is awakening from sleep to void. Those bladder muscles begin to weaken. There's an increased risk of infection resulting from incomplete bladder emptying. Incontinence is not a normal consequence of aging, but it is common. Female urinary incontinence is often caused by relaxed pelvic muscles that are related to childbirth trauma and the lack of estrogen after menopause. In men, urethral obstruction is often the problem, frequently from benign prostatic hyperplasia. The upper tract of the urinary system includes the kidneys, the renal pelvis, and the ureters. The lower tract includes the bladder, the urethra, and the pelvic floor muscles. True or false? The urethra are hollow tubes that extend from the kidneys to the bladder. This is false. Those are the ureters. So most people have two kidneys. They're located in the upper abdomen on either side of the vertebrae. So basically, they're really on the back. Two main areas of the kidneys are going to be the renal pelvis and the parenchyma. The parenchyma consists of the cortex, which is the outer layer structure. And within that cortex, we're going to find the nephrons, which are microscopic, and there's approximately 1 million of those. They are considered the smallest functioning renal structure. We're also going to find the glomerulus, afferent arterioles, the efferent arterioles, the Bowman capsule, the distal and proximal convoluted tubules, the loop of Henle, and the collecting tubule. With the medulla, we have the calces, which are the pyramids, that open into the renal pelvis and then empty into the ureter, which is the structure that transports urine to the bladder. So true or false, the nephron is the smallest functioning renal structure. And we know this is true. The urethrovesical unit is formed by the bladder, the urethra, and the pelvic floor muscles. The urinary bladder is a hollow muscular organ. Its shape and size are dependent on the client's age, the amount of urine that's contained in it, usually 300 to 500 mLs. The urethra is a hollow tube that begins at the bladder neck and it ends at the external meatus. In the male, the length is about 24 centimeters, but in the female, it's only about 4 centimeters. And then the pelvic floor muscles will form a sling which supports the bladder, the urethra, the rectum, and various reproductive organs. Urine is formed in 3 steps. We start off with glomerular filtration, which filters plasma and creates that glomerular filtrate. Tubular reabsorption will then occur in the tubular system of the nephron, where that glomerular filtrate is either reabsorbed or excreted in the urine. Tubular secretion will be the process of the urine passing from the renal pelvis into the ureter. Elimination, excuse me, involves the renal pelvis through the ureter into the bladder, and this is accomplished with a peristaltic action that moves the urine through the ureters all the way to the bladder. Urine reflux can occur if the bladder is overdistended or from urinary tract disorders, which can lead to infections. The nerve reflux is triggered when the bladder has approximately 150 mLs of urine in it, but it can hold more than that 150 mLs. And then the bladder muscle will contract and the sphincter muscles will relax to allow elimination of the urine. When we do our assessment of the renal system, we always need to get the history, including the chief complaint, any reproductive issues, and current medications the client is on. We need to do a physical examination and potentially some diagnostic tests, such as radiography, which for the kidney and the bladder would include a KUB, which stands for kidney, ureters, bladder, or just an x-ray. We may do ultrasounds, a CT or MRI, an angiography or cystoscopy, which would be visualization of the bladder's internal structures, or pylography, which is going to be an intravenous procedure where we inject radiological material into the veins so we can study the structure and the function of the KUB, and then taking x-rays as that radiopaque material then passes through the urinary system. We can do a retrograde pylography, which provides better visualization of the complete ureter, renal pelvis. This can be performed during a cystoscopy. It does carry the risk of sepsis and a severe UTI. A biopsy will diagnose any tissues, so it may diagnose cancer, it may assess prostatic enlargement. It monitors progression of renal disease and evaluates treatment of renal transplant rejection. But understand whenever we do a biopsy of anything that we have a risk of post-procedural hemorrhage. A cystogram would evaluate the bladder structure abnormalities and filling abilities. Avoiding cystourethropy would be a rapid series of x-rays while voiding. It is contraindicated if the client has a UTI. We can do urodynamic studies. When it's dynamic, we have constant movement or change. If it's static, things are staying the same. So urodynamic studies are going to evaluate the bladder, renal function. We can assess causes of reduced urinary flow, urinary retention, or incontinence. We can do a flowometry, cystomography. Urinalysis will study the urine itself. What is it composed of? What are its characteristics? And it can monitor efficacy of treatment of known urinary renal conditions. Those would include a urine culture and sensitivity, a 24-hour urine collection and urine protein. Remember, with the 24-hour urine collection, we are going to have the client void, and then we start the collection with the next void. We collect the urine for 24 hours. If they miss a void, we have to start the entire test over again. We need to keep the urine cold, so it either goes on ice or it is refrigerated. Urine-specific gravity and urine osmolality are other things that are observed with urinalysis. We can also do the blood urea nitrogen, the BUN, or creatinine clearance with that 24-hour urine collection to help measure renal function. Excuse me. So some of the procedures that we may see with the renal system would be those urinary catheters. Most urinary catheters are going to be introduced through the urethra into the bladder to help drain urine. And of course, the main complication is going to be the introduction of bacteria into the bladder. So this has to be a strictly aseptic technique. We can also do ureteral catheters, which are threaded through a ureter into the renal pelvis of the kidney during a cystoscopy or through an abdominal incision. A nephrostomy tube would be connected to a drainage system to drain urine from the kidney when the ureter is completely blocked. In other words, this is going to go directly into the kidney itself. A urinary stent is a hollow tube that would be placed within, let's say, the ureter, for example, to provide support to keep it from collapsing and allow that fluid to go through it. Remember, following any type of procedure or surgery of the urinary tract system, it will cause pink or blood-tinged urine. We've caused some irritation or trauma to those tissues. There may be a few small clots. This would not be unusual to see, and we do not consider that to be abnormal, but we would need to monitor for potential obstruction if we do see clots. Urological surgeries, one type would be nephrectomy, which is going to be the removal of the kidney. Lithotripsy would be the breaking up of stones with non-invasive type procedure. A cystectomy would be the removal of the bladder. There are some urinary diversions done to reroute the flow of urine. So basically, think about a colostomy, but it's going to be draining urine and not feces. The appliance device will be very similar to a colostomy device because it's going to be, it will have a stoma just like a colostomy will. And at the end of this device, though, for the urine, which we usually call a urostomy, it will have a device that we can actually drain the urine from without having to unclamp and reclamp like we do with the colostomy. It should be emptied about every 2 hours to help prevent leakage. It does tend to leak if it gets too heavy. It should, the adhesive wafer, just like with a colostomy, should be cut about 1/8 of an inch larger than the stoma to help prevent skin impairment. This skin is not designed to tolerate the urine on the skin, and it can cause skin breakdown very easily. A cystotomy is going to be the formation of an opening or stoma on the abdomen, and we often will do this directly above the pubic bone, so it's called a suprapubic catheter, and we'll insert a catheter in there to drain urine. Preoperatively, it may require the cleansing of the bowel because when we form this urinary diversion, we're usually going to remove a small portion of the intestine to help form this stoma. So we're doing basically 2 surgeries. We're cutting into the intestine itself, and we are going to be diverting the flow of urine. So we definitely want to have the bowel cleaned out if we're going to anticipate that procedure. Postoperatively, we have to monitor urine output, and we should expect the urine to be pink to red tinged initially. True or false? Performing an IVP carries the risk of sepsis or introduction of microbes, excuse me, which could then cause a urinary tract infection. This is false. In IVP, we're injecting IV contrast and then taking x-rays. And now your post-test.